So there's work plan there in terms of a 3-year strategic plan about how that workforce supply needs to evolve, how our clinical models need to change to address the demand and the financial challenges that we're facing. And obviously there's going to be some clear enablers there around support workforce, multi-skilled professions. Digital is going to be key for us in terms of transformation of our services. So they're the key bits.
So I'm just going to talk to page 34 of here. 3 quick areas I just want to sort of point out here, because we talk about mortality every time. You know me, I could talk through this all day. First of all, as you can see, actually our mortality rates have been dropping over the last few months. That is, if you go back and look at this on here, it's a very definite trend. It's the same as last year. However, we're at significantly lower levels than last year. We expect a lower level this time of year because we're looking at the sort of the May to July sort of report. We would expect that to increase, obviously, if you go to the winter months again. The other graph I just want to draw your attention to is one on the top right, which tracks us against the rest of Wales. Now, again, we are higher than the average there for Wales, but again, you can see that we're tracking very, very similarly across with the trends happen to us, trends happen across to everyone else as well. Again, the reasons I've explained before, and I'll just reiterate for any new IMs who I haven't had the opportunity to bore to death over this. We produce our data in a very different way in that we produce the actual admissions to the hospital and get deaths against that number. What the other health boards in Wales do have gone down the route of every admission they use, but they count every attendance in ED as an admission. Therefore, their denominator is a bigger number, therefore their overall mortality is less. So we are, when you put that into account, we are pretty much sitting in exactly the same position on that, but we don't feel it's the right thing to do to report like that because it looks like we're changing the numbers across the board. The big piece of work we're doing at the moment is this look at our total numbers. We must thank the bereavement team and the digital team. They've done a fantastic job at collating the data now as people are registering the deaths. Getting a lot more data, and I hope to bring to quality and safety the next time around at the starting process of what we're getting from that and how good that is. So we'll bring that to the next meeting. The only other thing I was going to just flag up temporarily is the new medical examiner process is now fully in effect across Wales and across the UK as a whole. This means now that any death certificate that is produced is no longer, it takes the coroner. Look, we always used to think the coroner had to agree to what we wrote on the death certificate. Actually, they had no statutory power to do that. But the medical exam service does have that. So we cannot now, as a clinician, sign off a death certificate. We must have the medical examiner agree with us as well. They independently look at those deaths. So that does put a slight delay into the system of relatives getting the death certificates through. That's not us doing that, but the data will show that we are delaying doing it. That will be the same for the whole of the UK. The reason being the opportunity to learn from it and flag any issues that we need to look into is much better than that scrutiny. So it's not great, but we need to explain that to our relatives when we can't really straight away. And I'm very happy because there's lots more to talk about here to do an IM briefing session on this area as well at any point if you would like to hear and explain a bit more detail. I'm happy to do that.
Right, Philip, I'll come to you next. Looking to report. Okay, thanks. And Harold.
Yeah, just a couple of things I wanted to highlight, and I'm looking at pages 26 and 27 of the report. So sickness has continued to stabilise and is very close to pre-COVID levels of sickness now, slightly above, but has continued to stabilise at that level. A couple of hotspot areas which we're doing some work on with nursing colleagues around HCA sickness, that's healthcare assistance, particular focus on mental health and also on scheduled care. Some hotspots around estates and facilities, which we're doing some work with estates and facilities colleagues on, and then in nursing, particularly around primary care nursing, which is a bit of a hotspot for us at the minute as well. But it is a huge benefit to us in the context of the conversation we had earlier that our sickness is coming back to more normalised levels. That said, I think I've said before, pre-pandemic, we were a bit of an outlier on sickness, so it's returning to a level that's higher than I'd expect it to be. So we're not satisfied with that, and we'll continue to push that and try and understand the causes of it. In terms of turnover then, some really good news there that we are actually lower. Said we were about the same, we're actually lower than 1920 pre-pandemic levels of nursing turnover, which is around about the 8.5% mark. The last reported in-month figure is actually below 8%. I can't remember a time when we were below 8% for nursing turnover. We've got to be careful on monthly turnover rates. We usually look at it over a year, but I'll take it. It's 7.8%. And the rolling for the year is at 8.54, which is down from 11.4 this time last year. And a peak, as I mentioned earlier, of around about the 15% mark. So that's huge again in the context of the challenges we spoke about earlier. Starter man training then, I feel like a bit of a stuck record on this in the sense that it just continues to slowly but steadily tick up towards target. So the main tier 1 target we have is around the level 1 training disciplines, and we are expected to achieve an 85% rate of compliance there. We're at 80.7. That's pretty good, and I think it's up near the best that I've seen it since I've been here. And PDR compliance continues to tick up as well. It's always challenging because just as many people are dropping off compliance as you're doing. But if we're continually ticking up, that means we're ahead of it, which is good. We just need to pick up the pace a little bit now and continue the focus. Winter obviously is always a challenge in terms of those types of things, but we'll continue the focus. And I just want to thank Care Group and clinical colleagues for all of the work that they're doing there. In amongst all of the pressures they've got to deal with by keeping those things going. We know that there is a direct link between PDR and having those regular conversations with staff and things like turnover, who'd have thought. So it's really important that we keep up the focus on that. That's probably all to say. Thank you.
Thanks, Charles. Okay, quite a lot there. Paul, anything for you before I go to the board?
Well, just on the performance that Sarah was describing, I mean, first thing to say is really good news that we've eliminated all the over 3 weights. Really, nobody has been that position anywhere but we were, and we needed to clear them, and we have cleared them. So that is a good step forward. I suppose just to say, there is a real focus. You'll know this because you all read the news and you listen to the media, but there is a real focus now on the waiting list pressure. Well, there has been for a while, but it continues, and it is probably the number one focus now with the government about bringing down the long waiters, particularly the 104s. And I think, as Sarah said, we've got a good plan. We are behind it at the moment, but I think the confidence is there that we will get it delivered. I think the issue around ophthalmology, we need to just make sure everyone is sighted on that. Sorry about the pun. But it is a really, really challenging position for the volume of people. I think it's about 1,300 patients, isn't it, that we have to do that are currently over 104.
Well, it will be above 104 by the 31st.
Exactly. Yeah. So that's a lot of people. The majority of those are cataracts. So we are working with our neighbours in Cardiff and AB to see what we can do on that. But I think it is probably the number one risk that sits around our delivery of that target. But the message on Tuesday at the Leadership Board of NHS Wales is you have to deliver the trajectory that you said you would deliver. So we, I think, have some thoughts that we Linda with our colleagues about how we can perhaps motor on a bit with that, and it will include things like looking at what other providers out there that we can outsource work to if we need to, which we've done previously or around ophthalmology as well. And the other area is it's a couple of areas for me. Cancer. It's really good to see that we are still planning to deliver the cancer ambition, but externally that number is still below where it needs to be. And I know it's because we're doing clearance from the back of the waiting list forward, but of course externally it looks like we are still not achieving. But I think that the work we're doing to get ourselves back on a steady state in the cancer trajectory is good. And final point is the other big bit, which is as quick as we're clearing people off the treatment side, we're also seeing a big increase in the number of people coming through as first outpatient referrals. So of course we've got to watch that as well, because if it's all well and good to clear the backlog of the long waiters, but if we're seeing an ever increasing number of people coming through the front door as first referrals, a large number of those will translate to treatment. So Linda and I were having a chat yesterday about how we can get underneath what's driving some of that. And of course, bearing in mind that nearly all of those people will be starting their pathway in primary care. There's something about does the demand pressure in outpatients reflect some of the demand pressure in primary care, whereby GPs are so swamped with work that sometimes it's just the easiest thing just to refer somebody on to the next stage of the pathway. We need to understand that, but we also need to understand, are there patterns by GP practice? Are there some practices that are referring more people into certain specialties? If there are, do we need to go out and do some education with them about alternatives to pathways? So I think there's a bit of work we're going to do, as well as Sarah, the piece of work you were describing at the outpatient efficiency. Once they're in the system, there's something for me about even going further downstream and saying, why are they even getting into the system in the first place? Are there some alternative options for these people? We've got the health pathways work, which Linda and her team have been working on with clinical teams. But yeah, I mean, good progress, but I guess I'm just nervous that the demand is still really, really high in those outpatient specialties, and we just need to keep an eye and make sure we're getting on top of that as well.
Karen.
Yeah, really good to hear all of that progress. I'm really interested in the reset fortnight, and I wonder if it probably at a development session, so it'd be good to hear a bit more about that and how that works and how we sustain the improvements that are made as a result of that. I wondered what the impact of all this has been on forwarding. What's the current situation with the demand and how many patients are being forwarded, whether we're still able to reduce that?
So yeah, it's had a great impact on boarding. We no longer triple board in PCH. We're not using any of the treatment rooms, so they are back to the purpose that they are designed for. We've been able to sustainably keep closed the surge capacity. So yeah, it's at the moment is sustainable. The plan will be how quickly we can do alternative sites so that we can roll out the same principles, because I think, you know, rolling this out at Princess of Wales and RGH is going to be quite critical in terms of our winter resilience. So, and it's not just that, there's little pockets of work going on around stroke. So for example, during reset, we ring-fenced stroke bed in Princess of Wales. That is currently being analysed in terms of the SNAP data, but that's looking quite positive. So it's not necessarily the big ticket items that make the difference, but sometimes the smaller things as well that we can influence. And then collectively that makes a difference to flow. One of the really positive outcomes was how we involved staff. So we set up Simply Do, which is a social media platform which allows colleagues all across CTM to get in touch with their suggestions. And ICTM were quite overwhelmed. We've had the highest response ever in rolling out anything like this, with over 200 staff registering. So we want to keep that going, because there were some really good suggestions from portering to pathology that we've been able to use to feed into our plans. So we want to keep that dialogue going so that staff are very much part of the solutions with us.
Thanks, Sarah. Ian and then Patsy. Thank you.
Yeah, I just wanted to come in on two things. One was the ophthalmology one that Paul's mentioned already, but it's good to see that some of this regional working is happening now. We can see some patients going to other areas, and I think private bodies, I think we use it as well, aren't we? It's good to see that's happening to some degree. I think this has been on for a long time, as we know. It'd be good to see maybe what the ground plan is to come back as a report to the board in the future. I'm sure that will happen.
Yeah.
But you know, it's been a concern for a while now, and I and others have been raising this for years now, I think, on the board. So I think it's such large numbers of patients. It'd be good to see what the grand plan is and how it's affecting things. The other area is orthopedics, of course. For orthopedics, we haven't mentioned, but that's a large area of concern as well. And it does mention in there that there are options to increase capacity are being explored, because we got a couple of large numbers of patients there as well. I wonder if maybe somebody could give some information on what the plans are there as well.
And Sarah, you correct me if I'm wrong here, but there's quite a bit of work going on, isn't there, within orthopedics to look across the 3 sites about a reconfiguration of things like the trauma rotors, which would then free up more elective operating capacity within the orthopedic surgeons, so that actually we can have more this planned joints, rather than everyone trying to do a bit of trauma and a bit of planned this. So that's a key part, Ian, of the strategy around orthopedics. I think that's the major part. I think I'm sure Sarah says this, Gethin's biggest issue, I think, around the 104s, around the risks, is ophthalmology. I think orthopedics, we are confident that we can get that back on track and can deliver. And ENT is the other risk area, but we're doing quite a lot of work on the ENT pathway based on some work that Cardiff have done to streamline their ENT pathway. And we believe that by adopting the same pathway as they've done, we'll be able to actually get the ENT patients treated as well. So I think I'm right there. Have I said the right things there, Sarah? Around it?
Yeah, nothing I can add to that. Thank you.
Patsy.
Yeah, just a couple of things. The index colonoscopy, it's a shame it was going really well and now it's dropped right down again. And I'm presuming that you're working in collaboration with finance for trying to get it back on track with the unfunded posts that are being put into colonoscopy. I've got a couple of things, so if I just go through them all. And I just wanted to say really well done on the 100% red release, which Sarah, you've already commented on. And stroke, I know there's been comments on stroke, but I wondered why POW, recognising what's been said now with the focus on the reset fortnight at POW, but why the stats for POW were less favourable than PCH. And it is quite significant in the information. And on Dom's point on the medical examiner's office, personal experience over the last few weeks, unfortunately, it has added a significant step, but a difficult step, because the relatives don't actually speak to the medical examiner's office. We still go through the coroner, which is what I had to do in the past. And then the coroner relays to the medical examiner's office, who makes the ultimate decision. And that has added a difficult step and a lot of time.
Yeah, because specifically on that point, that is now the law about the way things have to go. It's gone through Parliament, so it applies to all nations. And what's meant to be happening is the medical examiner should be contacting the families directly and taking the coroner out of the loop. And that's the next step that should be putting into place.
That will be better.
Yeah, so that means that only in the case they have to refer to the coroner, go to the coroner. They only see that, wasn't it? Everything else gets away. I think some jurisdictions in coroners have tried to keep it, but it will be changing.
Next one. Anything else, Patsy?
No,
No.
we were good.
Thank you very much. I'll come to, perhaps I'll take some questions again, then perhaps if we have some response on those key points, if we haven't covered them off. Rachel and then Kath.
Very quick question of curiosity, I think, for Greg. The C. diff stats, Greg, is it a particular age group that's affected by the community?
Mostly elderly. Yeah.
And I just wondered whether, I thought so. I just wanted to check, and I wondered whether that was having an impact on the number of older people being admitted, and then, you know, if we could crack the issue of why they captured it, and it was the antibiotic thing that probably why.
And now we've got more pharmacy provision within primary care, working, you know, within the GP or supporting GP prescribing. I definitely think we'll see a gear shift change, but it's mostly the elderly.
Yeah. Okay. Thank you.
Thanks, Kath.
Yeah, I was just going to mention in Quality and Safety Committee, we had an update around dentistry and sort of waiting times around theatres. And I think that's another one that we need to be sort of watching. And I know there's sort of work in progress, but there are some people who have been waiting quite a long time. And I think COVID had a really big impact on that as well.
Yeah.
So I just wanted to sort of raise that as well. Yeah.
Thanks. Just two very quick points from me. The first one is around narrative. How we describe the rates of activity, how we describe the demand that we are now seeing month in, month out, and how we use that to describe not only to colleagues in government, but also to our communities about the scale of the demand for our health services. So in the past 24 hours, there's been a cancer story on BBC Wales website. Professor Tom Crosby, the National Clinical Lead for Cancer, was quoted, and Tom said the demand is outstripping supply of both capacity and clinical staff. Okay, now that is not just in cancer. We know that is the issue in a number of our services. So how we describe the amount of activity that we're now dealing with, and where numerically that activity is compared to last year, the year before, 5 years ago, etc. I think we need to be better at describing how much we as a health board actually physically do, because whilst there is an inevitable focus, and understandably so, on the numbers of people waiting and the length of time that people are waiting, there is very little focus on the amount of work that is actually physically done compared to X number of years ago. And I think it would be worth perhaps, I know these performance reports are built in a certain way because we've got the dashboard that sustains all of this. But I think in some of the narrative in the future, it would be good to remind ourselves and therefore to remind everybody else about the scale of the work we're actually physically doing, not just the scale of the challenge of meeting the needs of those people who we have yet to see in our services. So that's the first point. The second point, I just want to say a huge congratulations and thank you to the staff for delivering the eradication of those long waits, the huge improvement that we've seen in our CAMP services, the steady but sure improvement in the delivery of some of our cancer services. You know, these are noticeable improvements from where we have been as a health board. There are some challenges. Paul's alerted the board to the fact that demand at the other end of people that we've yet to see is coming through thicker and faster. So if, for example, we look at the number of people waiting more than 52 weeks for a new outpatient appointment, we saw those figures going up in our July board meeting. They've gone up even further since that point. So our trajectory has been set to bring that down to zero by March of next year, 6 months. And yet we're 10,000 beyond where we should be at this point. So that is a really big challenge for us to address. And I think as part of this, there's some mitigation in here, but I think maybe as part of this work, perhaps within our board development sessions, we might want to spend some time considering, okay, so the numbers are going up. What is it that we need to try and put in place to correct that? It's the same because the trajectory that we're currently on is not the one that we should be on, has changed as well for those waiting for more than 52 weeks. And that's continued to rise compared to the board meeting in July of this year. So, we're making some really good progress, but we're still facing significant challenges of the numbers of people coming into services. And my fellow health board chairs are saying the same thing, particularly around cancer, the demand for cancer services, and the demand and the referrals are just going up and up and up. So, to me, this comes down to a capacity versus demand conversation, as well as a conversation about how we use our capacity more effectively. So I don't know whether we want to try and pull some of this out into a particular session, but it'd be good to give some focus to it because we are under a lot of pressure to eradicate some of these numbers within 6 months. That's a heck of a time scale to try and deliver on. And at the moment, I would say that we would struggle to get there. But
I agree, John. And I think I'm just thinking whether, to your point about a session on that, I think maybe Linda also, we've done a lot of work on the health pathways work, which is about trying to look at alternative direct. So when people see a GP, the GP's having other things at their disposal rather than just referring them on to a specialist and looking at other options for them. So maybe we could do a session about that and sort of the wider work that's going on around different pathway redesign.
Well, exactly that, because there's lots of other things that can be done, directed test, advice and guidance, as an alternative to first outpatient appointment. So I think is it PIT, isn't it? Is the planned care recovery. I know that they're looking at all of that, so we can do a whole big update.
Thanks. Linda, just very, very quickly, I did say 2 points. There's a third, and it is around the straight to test. Our straight to test numbers are far lower than other health boards, and I'm just wondering if we could explain to colleagues why that is the case. Is there a view that by pushing straight to test too heavily, it impedes clinical judgment, because there may be good clinical judgment, which is why somebody's not sent straight to test. And this is something that's been highlighted by officials as to why our figures seem to be quite markedly different compared to other health boards.
Right, so I'm going to jump in Linda and Dom. There are mixed views on this, right? Because yes, the theory goes, if you're a GP and you see somebody you clearly think that they need to test, you need to be able to get them into, I don't know, an endoscopy or an MR or whatever. There's also a counterbalance that says, if you are too open access with tests, everyone gets referred for a test, and therefore the services get swamped with people who don't need to be seen. So I'm not saying we shouldn't be doing it, but I think it's got to be done with a framework around it, with some guidelines for primary care. So it may be done. It's part of that pathway from primary care and secondary care. I think what this is saying is, let's be honest, the current pathway from primary care and secondary care hasn't really changed since the 1950s, right? So see a GP says, I think you need to see a specialist, refer to a specialist, specialist goes on for diagnostics, they go back to the specialist. So there's something here about actually is how do you redesign that whole pathway? If you can get GPs and specialists talking more actively together, as Linda said, things like advice and guidance lines, where basically the GP's got a patient they're a bit unsure about, they can just pick up the phone and have some advice and a chat with the specialist. And that may say, the specialist might say, no, you don't need to send them into me, just do A, B, and C, and you'll probably be able to manage them in primary care. There's lots of options that we could be doing to try and change that pathway. So I think maybe having a session where we can talk about what's our current model and things we're doing, but also what could we be doing differently and what could we do to expand it.
I was going to say, I agree with that. I think there are pockets where it does happen. And the electronic referral system is really important for that, because that enables that two-way communication. And it can be that a patient will refer to the colorectal surgeons and say, actually, do the CT or do this, and then the correct process is followed.
Exactly.
And again, with the health pathways, that's really going to help with the straight to test, but in an appropriate way.
That's the thing, isn't it?
Yes.
Yeah, I think I was just saying on that, the health pathways help side. I think that in the absence of there being a clear pathway, today's way medicine is let's get the test done and do it. And you look at our CT rates across ED, I think our CTs are much higher than probably clinically indicated, because there's not so much a defensive medicine, but it's well, that'll give us the answer straight away. And it's a quicker way of doing things, as opposed to applying clinical acumen and judgment to it. So I think there's an element of it's simply slope that we've sort of got ourselves on, so that we need to arrest slightly. But I think the health party will really help with that. And that discussion to primary secondary care, that barrier, we keep talking about it, don't we? But we break that down, that will resolve a huge amount of it.
Okay. Thanks, Tom. Okay, any other questions or comments on the performance report? No, colleagues happy to note it. Thank you very much. Moving on to 7.2,
Sarah, if you need to go now.
Sarah, if you need to leave, then please do so. I know you're flat out this morning.
Lovely. Thank you. Thanks all.
Cheers. Okay, we've got the month 5 finance report. Mark, I'll hand over to you to pull up the key highlights. Thank you.
Thank you, Chair. This is our standard finance report for month 5, and taking the report as read. I'm recognising we've got another meeting on this later today. At this point, I think there's only 3 pages I want to sort of highlight and draw out. If I could take you firstly to page 3, which is the summary. Just on the overall position for 24-25 on the revenue side. Month 5 position was a 0.2 million surplus, which was a pleasing improvement. But the year-to-date position is still a 3.9 million deficit. And the main driver of that deficit continues to be the shortfall in savings delivery. We've still maintained the forecast break-even position at month 5, but the level of risks still remains high. And I think there is now a significant risk that we may not be able to hold this position for the rest of the year. The net risks to the forecast now stand at 14 million. Although that's a reduction from where we were last month, it's still a very significant risk level to be managed. The next page then is just, if I could take you to page 8. This shows our latest bottom-up forecast, which are coming from the care groups and the directorates. And that's actually indicating an overspend of 3.8 million at month 5. The 4 main components of that deficit position is firstly, as I mentioned, the shortfall in savings. So we are currently forecasting a 14 million gap against the 26.3 million target. We then got some, if you like, unexpected operating variances, which are quite significant over and above the plan that we set. And that's running at about 8.6 million. Offsetting those 2 deteriorations, then we've got 2 areas of improvement. One is the financial plan improvements, where we set aside funding in the plan for certain things that we thought would happen. So we have got some benefits where they haven't arisen. So that's giving us a forecast 12.4 million offset. And then we've also got accountancy gains, which is where we're reviewing our balance sheet position to see what can we take off the balance sheet to put the benefit towards the bottom line. So that's what gets us to the 3.8 million forecast deficit at this point in time. So we therefore need additional savings of at least 3.8 million to get back to our break-even forecast. But I think the important thing is that this understates the challenge because of the other significant risk that we still need to manage as well. And if I could take you then to page 18, which then sort of describes some of those risks. This is our latest risk assessment. So it's showing, as I said, 14 million of net risks at month 5, a slight improvement from where we were at month 4. The 14 million, in effect, that comprises the 3.8 million forecast gap that I referred to, because we haven't got plans to deliver that gap at this moment. And then we've got other risks of 10.2 million, which are described there. I was going to go into those in a bit more detail later today. But I think the key point, as I said, at month 5, there is a significant risk that we may not be able to manage all of these risks, which would then result in a deterioration to both our in-year forecast and also, importantly, our recurring position going into next year. I'll stop there. Obviously, we've got the other session later, but I'm happy to take any questions at this point.
Thank you, Mark. Much appreciated, and thanks for taking us through the presentation. Any questions, Patsy?
Yeah, just one comment really on the accountancy gain being taken so early in the financial year. Is there a risk of people within the organisation not recognising how serious the financial position is by taking that accountancy gain at this stage? Normally you sort of feed it in the last quarter.
We don't. We've
always
brought it in. In fact, in previous years, it's been part of our plan. You know, we brought it in.
Yeah, I recognise it.
So no, this is not unexpected for us. I think that page 8 there is being totally transparent on the position, and I think it doesn't underestimate that we've still got a very significant challenge even after bringing in the accountancy.
Mark, one of the pressures that went beyond what we'd anticipated this year was the primary care prescribing budget, and the growth, I think, in the past few months, I think, was hitting around the 10% mark, but we budgeted for about 5%. That starts to come down a bit now, as I understand it.
Yeah, that's still in that forecast position. I think there's about 3.5 million as part of the operating variances. So we've still got an issue with primary care prescribing growth. What's not visible in that schedule is that growth has gone the wrong way, but we have got better benefits than we anticipated in the plan for primary care prescribing price changes.
Yeah.
So the category M price changes have improved and has offset that. It's just that we cover them in different places.
Right. Yeah. Okay. Any other questions or comments on the financial position? Where we are now, I know it's not where we'd hoped we would be, because we are at variance compared to what we set out at the start of the financial year. So I suppose the question for us is, to what extent those efficiency savings can be delivered in the course of the year? To what extent can we recoup that 3.8, if at all? And are there pieces of work that can be done in the year to make a meaningful difference to our what is now a projected overspend in the context of this report? And I'm very conscious that by Monday of next week, we conclude 6 months of this financial year. So this is quite a challenging position to be in. But I know there's a lot of work being done by you and Sally, the team, the care groups and others to address that, which is terrific. But obviously accepting the fact that this is, a very challenging financial picture that we face. In terms of the demand picture, in terms of what the care groups have experienced, is most of that around unscheduled care?
A lot of it is in unscheduled care, but I think it's fair to say that nearly all of the care groups are forecasting more spend positions.
Yeah. I mean, Gethin, I know, is working closely with Mark and the care group directors to look at how those operational overspends can be brought back in line. And I think there's a range of actions that care groups are taking to try and do that. And I think you've had some, there's been some positive engagement from the care groups there to try and find. I mean, they're all dealing with, big pressures at the moment. I think though, having Sarah's description of some of improvements that have been made around flow and therefore the reduction in the need for some of the escalation capacity, that sort of thing helps, because of course that means we don't need to then bring in the escalate, extra nursing staff to staff up escalation beds. So there is a lot of work going on it. But I think it's fair to say, everyone is really, trying their best, but it's really tough to hold the position when the pressures are so significant. And things like vacancies in medical posts, having to cover both in rotas and all those sorts of things are operational stuff that everyone's trying to sort of balance the need to make sure services can be kept safe and we can provide the right care for the patients whilst also making sure that we're delivering on a financial plan. And again, in the same way we had a very clear message on Tuesday about the performance, we also had a very clear message about the financial ambition, saying that, that the Welsh Government plan for financial delivery is based on organisations delivering the plans that they said they were going to deliver. And there isn't much latitude should people start to veer off. So it is this never-ending juggling of quality, safety, experience, performance and money.
Yeah. Sorry, Mark and then Sally.
Yeah, I'm just going to say, in essence, we have still maintained the break-even position at that size. So that's what we reported to Welsh Government.
Yeah.
We are flagging the risk. In summary, I guess it's the bottom-up forecast. If they are all accurate, we got a 3.8 million, which isn't the major problem. No. The major problem is we got 10 million of other risks that we need to manage. So the challenge is how do we find an additional 3.8, but also manage
the other risks.
The other risks. Yeah. And we come on to that a bit later in a bit more detail, but we can share some of the care group information. We can share some of the recovery planning processes that Getty and Sally and myself are running at the moment with the care group. So there is some benefits coming out of that, and we are continuing to run that. So we're doing all that we can to mitigate the position, not only on an in-year basis, but importantly, how do we get back to recurrent balance in the care group so that we go into next year with a solid plan.
Yeah, thanks.
Sally?
Yeah, I think I've got a couple of points. I think one, that as a sort of jobbing clinician on the shop floor to a degree, I fully accept that we have to be scrutinising what we're spending. This is public money, and it has to be spent appropriately. I think we need to continue with our emphasis to make sure that we're not overspending, but also bearing in mind that we need to continue with ensuring that our clinical standards and our safety and all that needs to be maintained as well. And I think the other thing that just came into my head then as you were speaking is that we're still trying to make savings whilst working more or less in the same way. And I think Linda coming on to talking about the acute clinical services plan, whether we need to be investing in that as an investor save, because if we invest in being able to bring that in line and bring that on as quickly as we can within the framework that we have to follow, I can imagine that would bring us more significant savings.
Yeah.
Thank you, Sally. And can I say that, as chair of the board, I'm acutely aware of the challenge that I set and the challenge that Paul set to the entire organisation, that we wanted to deliver a break-even position this year. We're the only health board that was able to write a plan that would balance in the year, and the only health board to have its IMTP signed off by the minister. And I know how challenging that is for the organisation to do in any climate, let alone some of the most challenging climates that we've seen. So I really do appreciate the enormity of the effort that people have put in to find how we can be more effective, more efficient in what we do and how we do it, and how our resources are spent. So we've always said this was going to be a huge challenge. I think it's right that we're reporting that the forecast break-even position now, and I know that further work hopefully will see us in a better position as we go into the second 6 months of the financial year. But Mark, a huge thanks to you and Sally and the team, but also all of our colleagues who have been engaging and attempting to hold the line, but because it's been the right thing to do. This is public money. It's absolutely right that we are more effective and efficient how we spend it. And I really appreciate where we are as a health board. We compare us certainly to the rest of the system, which is in a much challenged position.
We share a bit of the comparative stuff.
Yeah, absolutely. Thanks, Mark. Thank you. Thank you much indeed. Okay, we'll move on to item 8, which is the acute clinical services plan update under our strategic planning section. Linda, I'll hand over to you. Thank you.
So just very briefly for me, obviously, this is how we're going to approach a model of care that takes us into a balanced, affordable, quality system and of care. It links, of course, to our community development that we've heard about earlier. It's all part of the same, two sides of the same coin. And maybe the third side, if I'm allowed, a third side of my coin is the work that we're doing in building healthier communities, because the more people are taking care of themselves and our public health agenda is being driven, the less that also contributes, doesn't it, to managing demands on our system. But if we're going to get this right, we know that the way that our services are configured right now isn't conducive to meeting some of those demands in the future. So we've got a great idea about how we're going to move forward on this. We've heard, haven't we, that in order to move forward, we've got to do our public engagement well and right, because it's not a question of whether we get challenged further down the line. It's a question of, are we robust enough to withstand that challenge? As much as we can sell the idea and really bring people with us, it only takes one or two people to decide that they need that there's going to be that challenge. So we've got a bit of money this year. We're doing all we can with that to prepare for a really good set of processes next year that really embrace everything that I've just said. So there is a need to bring in additional program director. We can't. We're working on that, but we can't actually proceed with that because the money we've got is non-recurrent for this year only. So I need to know that we're clear about how we're going to deal with that going forward. We're working with all the directorates, continuing to do so, but almost every directorate has said to us, given the scale of what we're doing here, which is to reconfigure everything, we need some additional resource in our team to do that. We've costed that, we know what that is, but we don't have the cash to put in right now. Although, having said that, people are doing great work, both in terms of keeping on top of reporting on the status of services, big old spreadsheet, and flagging things appropriately into risk registers. So we're keeping on top of what our baseline assessment is of our services. Simon's about to secure some external support to do the stakeholder mapping ready for the engagement, to get that up front. And we've actually just secured some help to work with our acute medical teams around a future model of care and what evidence is showing us that needs to be in the future. So a couple of little bits to build there. We've looked at how others have presented their case for change, because we're trying to get ahead with that as well. And that has helped with the building of Andrew Nelson, Andrew Jones, and Nicola Evans from respectively performance or information, HR and finance. There's one way around. Are building a good baseline model, a model that we can then play tunes on. So we can show line by line, service by service, activity, cost, staff, and then as we move it, we can sort of adjust, it can then show us what the new costs can be, what the new workforce is going to be. So it's not there yet, but they've made some great strides forward. So people are really working hard on this in the background to get the kind of widgets in place so that we can move forward as quickly as possible. But I would say that, with the delay, and I didn't pay Sally to make that point, but we can't. We're always going to be struggling, both in terms of aligning our resources to our services. At the same time, and Dan knows this from Clyce, we're getting the pressures increasing on some of these services that are spread a bit thin, and we are having to consider more cases for urgent change, and which we can't make permanent until we've done that consultation. I can't stress this enough. And I know that we've just heard how difficult our finances are, but there is an investor safe case here, and the sooner we can bring that forward, the quicker we'll be coming through the other end.
Thank you, Linda. That's really helpful. Okay, any questions to Linda on the update? Any comments? it might be, Linda, that I think we're going to identify one of the board development sessions for further update anyway. Which may be before the end of the calendar year, but perhaps we can look at a bit more detail things like time scale and some of those, managing some of those risks. Paul?
Yeah. Well, I think Linda's last point there is the really important point, is that we need to go and model what the scale of the opportunity looks like.
Yeah.
And that will then help us build the case to say, if the scale of the opportunity is X, then spending Y to get to that is the right thing to do. Because we can't, as we all know, for a variety of reasons, we can't carry on with the existing models that we've got. So I do think getting the groundwork that Linda and the team are doing now to sort of build this, those opportunities, specifications, is really important. And as we've also said, this isn't just about the acute part of the equation. We're in parallel also starting up quite a big program of work now on the primary and community side of the equation, to look at how we can make sure, because it's no good us making these assumptions that we can move these things out into the community and we haven't got the community and primary care infrastructure to be able to deliver it. So we've got to do the two things in tandem. So there's another piece of work we're looking to do, some work which we're setting up a primary community transformation board, I'm in the chair, which we're looking to make sure, how do we build that resilience and capacity in the primary community teams, so that when we're starting to talk about some of these specialties, transitioning things into community, we've got the capacity there to do it. So it's quite a complex sequencing of events that need to all be sort of lined up in the right place. But it's also, the challenge at the moment of asking people who've got very, very busy day jobs to deliver their savings plans for this year, for example, in the care group, to then also say, can you sit down in a darkened room and now decide what you think a future model of service looks like for the next 20 years in your area, or what the digital transformation opportunities can look like, or what your workforce plan is going to look like. So I just think, if that is this, we can't carry on just going year by year by year, getting through our financial challenges. We've got to have a bit of a longer term plan that says, how do we take ourselves on the journey as an organisation? It goes back to the point about the committees as well. That's the sort of conversation we need to be having in the strategy committee, which is, where are we going to be in 5 years' time as an organisation, from a clinical service model, financial model, workforce model, digital infrastructure, etc. So lots to do, but I think, we do need to think carefully about how we're going to make sure we get the right resource behind it, because we don't want to start this half-baked and then fall at the first hurdle.
Okay, Linda, thank you for the update. I think we're going to move on to item 8.2, which is the update on Clantress and Health Park. And this is point manager.
Let Mr.
Okay. Great to see Rosie and Glenys. Rosie Campbell is our programme director, and Glenys Mansfield, both here to give us an update on where we've got to with delivering our Clantress and Health Park. Thank you both. Over to you.
I was just conscious that there's a lot of work going on LHP behind the scenes, and I was conscious that as a board we haven't had the opportunity to have that conversation recently. I only this week was having a conversation with my colleagues about it, and I guess just talked about what the future looks like and the strategy. This is a fundamental part of what the future model looks like, and a really exciting opportunity to showcase, not just for our patch and the region, but for the whole of Wales, what a future model of delivery can look like for elective care and for diagnostics. And really, really exciting opportunity. So great to have Rosie and Glenys here, I think it's a fundamental sort of priority, and what a topic we probably need to be talking about more actively in our board moving forward. So yeah, Rob to Rosie.
Thanks, Rosie.
Thank you. Right, good afternoon, everyone. So what we intend doing, as Paul and John have just outlined, is just giving an update on the progress to date of the work on the Clantress and Health Park programme. This slide just sets out our general approach. We'll look at progress to date, including the mobile MR, and then the next steps that we've taken in terms of development of the design and the proposed way forward. If we could move on. Thank you. So just to recap, we installed a mobile MRI on the site, and that became operational on the 20th of April. Since that time, We have scanned just under 2,000 patients. The mobile is actually coming off on Saturday to be replaced by a CT. But by the time it comes up, it will have scanned over 2,000 patients, which has been a really good achievement. It's seen a significant reduction in waiting times for MR and has been really positively received. And I think this has been the first indication really of the opportunity that we've got on the LHP site. Patients that have visited have felt very positively about the ease of access, the ability to just park up and be seen very, very quickly, and the convenience of being able to do so. And that the MR has focused predominantly on patients from both Bridgend and Royal Glam, but there have been PCH patients as well. So they have all responded positively to its presence. As I said before, we're mobile CT will actually be arriving on Monday and is planned to be operational on Tuesday. So if we can move on, thank you. So if we move on to the main site and the main design, just conscious of the fact that it's been a few months since we've given you a formal update, want to make sure that everyone is aware of progress to date and how things have moved forward. Since we purchased the site, we've undertaken some very, very detailed, comprehensive surveys and analysis of how we can best use the site, with the objective really of maximising the clinical services that we've got on there, being able to work effectively and having a future focused sustainable development on the park. One of the key elements that came out of the study was that there were lots of limitations in the current buildings. So after undertaking an options appraisal, we've considered the best solution would be the replacement of the buildings that are on site. Just to stress, the site is absolutely perfect in terms of its infrastructure and ability to support us, but the buildings themselves were designed for slightly more light industrial use. We always knew that this would be an option to accommodate the level of services that we want, and we'll go through that later in the slide pack. The best option was going to be to take the buildings down. If we just move on, so the big benefits that they will give us, well, it's going to give us a shorter programme, a lowest cost, but it also gives us 40 plus years. And we have to bear in mind the buildings over there already been on there for nearly 30 years. So they were already well through their lifespan. It just gives us lots of opportunities in terms of how much capacity we can support, gives us opportunities for future expansion on the site as well. And it just gives us the ability to accommodate all that we want to give us a future focused service. So that was presented to Welsh Government initially back in the spring, and that is the basis on which all of our design work has moved forward. I'm going to hand over to Glenys now to talk through a lot of the clinical pathway work, which has been instrumental in taking the design work forward.
Okay, thank you, Rosie. Good afternoon, everyone. I think, as Rosie alluded to, this is a great opportunity in terms of almost starting from scratch and being able to design the clinical pathway. So been very clear that this is very much the patient is the centre of everything we're doing, from design to delivery to the quality we want to do. And it's very much been clinically driven in terms of how we're progressing. So it's very, again, transforming services and using opportunities to challenge traditional practice. Is that the best way of doing things? And making this an exemplar unit, we see it as being sort of the exemplar start of what should be across Wales if we move forward into sort of elective type treatment centres, of which this will be the first purpose built and first sort of delivery in the way we're looking at. So I'll touch on that sort of surgical hub blueprint. Looking at sort of the clinical model, it's around, we've been and visited a number of sites, we've looked at best practice, we've looked at what do they do abroad, internationally, in order to sort of feed through to how we've designed that clinical pathway. So you'll see as we progress through that we're looking at the different terminology, different approach, different mindset to things. So where we all talk about looking at sort of hip and knee replacements and hospital stays, we're now calling that a day case procedure. There are centres, and we've been to Exeter Nightingale Centre, where they do 80% of their joint replacements are done as day cases. And that's much better for patients. I'd much rather be at home and in my comfort of my own sofa. And so we're aiming that this will be one of our sort of starting points. Will be, we might not be at 80% because our demographics are obviously a bit different than Exeter. And so that arthroplasty becomes a day surgery procedure, not an inpatient. So very much moving away from that hospital stay focus.
And our outpatients, our day surgery, we're not calling it day surgery, it will be outpatient surgery. Because again, people think of day surgery and you're going into hospital, you're there for the day. No, you're coming in, you'll have your procedure, and as soon as you're well enough, you'll be out. So very much that high flow, low complexity services for patients, which also means that makes us more efficient. We can get more patients through and treat more people. That's the eye witter on I do. I don't look at my slides because I get so passionate about what we're trying to do. So I think we've worked very closely with clinicians. We work very closely for the orthopaedics regionally as well. We've got the clinical lead for the All Wales Orthopaedics very much on board with what we're doing and supporting our development of pathways. So we're very linked in. We're also very much linked in with all the All Wales work that's happening around anaesthesia and around orthopaedics. I'm hoping that we will help to be a catalyst to change some of those things across the other health boards and not just within CTM, because it gives us a very much a unique opportunity. We've developed a set of principles that we will apply to the unit for both staff and for patients in terms of inclusivity and what can go there. Trying to sort of break down some of the boundaries and the barriers. We've later on this afternoon, we've got LHP programme board where we'll be talking through an example of sort of trying to look at innovation. We've done a detailed piece of work around, do we have barn theatres where the theatres are sort of open, or do we have traditional theatres? And I have to say, up until 12 months ago, I didn't even know what a barn theatre was. And so we've done research, visits, evidence base, talked to lots of different infection control to make sure that we come up with the right solution for now and what's future proofing as well for us. Because as Rosie said, 40 years time, we still want to have a facility that is able to deliver and progress as healthcare progresses in the coming years. Okay. And the clinical side of it, we are in the process, we meet with clinicians now, but setting up clinical reference groups. So as we go through the design of those pathways and challenge some of the ways of doing things, we will be looking at standardization. We'll be saying, if you're coming to LHP and you're going to do X procedure, here's what you would use to do that. You're not going to have a choice of 6 different items on the shelf. You'll have a choice of one. But it'll be clinically based. The clinicians will decide what that one is. And that will help us become very efficient. And I think we'll be looking at being able to support the quality of what we deliver, but also a cost efficient and effective service when it's up and running and be able to demonstrate that. And so therefore value for money. And I think if you look at Exeter, where they've got their Nightingale Hospital, which just does arthroplasty, that has influenced and changed practice across all of the trusts in their locality. And they've seen in their secondary care hospitals, their arthroplasty, joint replacement, length of stay drop there by 3 days because of the work that's happening at the Nightingale Exeter. If you put that across sort of South East Wales, if you can reduce that length of stay, that's a huge plus for patients across the whole region. Thanks, Glenys.
So taking on board where we've got to, we've had a lot of multidisciplinary meetings and we've used a lot of pathway work that has been signed off by these groups to feed into how the design works. So what I'm going to share with you over the next few slides is some massing diagrams and some plans that have been drawn up for the design stage that we've got to. We've got something called REMA Stage 2, which is the Royal Institute of British Architects. They have different stages of design. So these are about 1 to 200s. They are informing us for our pre-application for planning, where we go out early and talk to our planning officers about what we're proposing to do, make sure everyone's on board, make sure everyone's comfortable with it. But it also, I think, starts to make this very real. They start to look like real buildings. So if we can move on to the first one. Now, this is just a very simple, it's not going to be this white, don't worry.
You would say that quite.
Well, exactly. We do plan on making it slightly more interesting. Basic impression of how this will sit on the site. Now, I'm hoping some of you in the room have had an opportunity to visit the site. But as you can see, as you just drive in, there will still be the buildings along the front, but instead of being 3 very separate buildings, they will be slightly more joined up and interlinked. But it just brings home the scale, I think, of what we are trying to do here. So we move on to the next slide. You can just see in a plan format that we still have
Explain, Rosie, where's the driveway in, just so people can sort of orientate themselves. Yeah.
It's really hard. I need like a little pen. Okay. So as you come off the road from the roundabout, this is where you drive in.
Right.
So often now, if you drive to the back entrance of Royal Glam, you'll see the little security hut and the gate. So this is where we drive in. This is the first building. Now this is intended to be the diagnostic hub. At the moment, the mobile MR is parked out here, and that pad will stay. So that will give us flexibility and ability to potentially bring in something like a PET scanner if we needed to in the future, but also at times where we need to replace a machine, we don't have to lose capacity. So this is very much planned to be the CDH. Although linked to the other buildings, it will operate as a standalone. It will have its own entry, and this is where the intention is that we'll have MR, CT, ultrasound on the ground floor. First floor will house endoscopy rooms, and above that is proposed to be the endoscopy academy. So this is the only proposed 3-story building at the moment. The wonderful thing about the site, and this is what we will maintain, is there is this road along the back that gives us our access road. Buildings B and C, these will comprise of the surgical hub. We will have 6 day theatres and a fully enclosed day surgery unit on the ground floor of C. And on the first floor, we'll have 6 orthopaedic theatres. B will have the supporting trolleys and beds for the currently inpatient arthroplasty. Now, as those lengths of stay drop down, as bed requirements reduce, there is an opportunity on that ground floor, because they'll all be single rooms, to look at expansion of services, use of those as further consulting or procedure rooms. So the key will be to maintain absolute flexibility within the building that we've got. Then here, we've still got a space, as you'll see, for consideration of further potential regional services that can come onto the site. So this is probably going to be quite difficult to read, but this is the real level of detail that we've got to now. So we'll see over here, we're proposing to have the 6 theatres. What you'll note on the ground floor and the first floor is to make this as easy to build as possible and as quick to build as possible, we will be stacking them. So theatres will be above theatres. This gives us massive efficiencies in terms of how our plant and how all the technical support runs. We will also look to standardise as many spaces as we can. A consulting room over here will be the same as a consulting room over here. Everything will be as uniform, standard and straightforward as we can. But as you'll see, this is proposed to be the diagnostics. And if we move on, you'll see on the first floor, we've got endoscopy up here. And again, you've got your theatres, your recovery and your inpatient units. And the second floor, if we just move on, is purely the endoscopy academy at the moment. And obviously we're in discussions around how that works. There will be a fair amount of plant, so the roof base will be occupied by a lot of plant. There is a lot of technical support for this site. Running 12 theatres is quite energy intensive. So if we move on, please. Okay, so in terms of the programme, at the moment, looking at a straight technical programme development, factoring and planning and everything else, we're still looking at not finishing all works on that site until August 2027. But what we are looking to do is to phase how we can bring different services online as early as possible. The key for us is to try and get the buildings demolished as quickly as we can, and that leaves the space open for us to try and bring forward services as quickly as possible. We're looking at bringing contractors on board. We want to appoint our contractor now as we get to the end of the REBA 2 stage and head straight into REBA 3, subject to funding. If we bring them on board now, get them integrated in the design work, really pushing it through, that should give us further efficiencies then when it comes to build and deliverability. We're also investigating with Welsh Government how we can shorten business case processes, administrative processes, maintaining governance, understanding this is a significant investment across Wales. This is using public money. We need to prove value for money. We need to get this right, but also we need to get this done properly and quickly. And we need to get this service up and running and delivering as quickly as we can for patients. So if we just move on to, this is just a diagrammatic of the programme. What we have to say is this is, for a construction project, this remains a very ambitious programme. We're not factoring any time for approvals. stages of approvals, giving Welsh Government 4 to 6 weeks to scrutinise X, Y and Z and return it. We are looking, and there will be a degree of risk in this, we are looking at proceeding from one stage to the next whilst all these sign-offs are done. That keeps us moving, that keeps our design teams on board, that stops any stagnation in the programme. But it is ambitious. We will be pushing our planning colleagues to come back to us for approvals to come well within statutory timelines, and we will keep that pressure on. Now, certainly discussions that we've had with the planning department, I have to say, have been really positive. They have been very proactive with us, and we are hoping to keep all of that forward, because actually our critical part does sit around all the requirements around planning. So if we can just move on just to outline. So after all of that, the next steps are we've submitted a strategic overview case, just confirming the scope to Welsh Government. As Paul has said, there was a positive meeting on that yesterday. But we do need to keep chipping at how we can bring that programme back. We all think there are opportunities within there, but it's just about how we can realise them, how we can release them, getting the right construction partner, getting the right construction methodology as well, to keep bringing that programme back, to bring forward those operational dates. Our REBA 2 completes on the 15th of October. That is already quite a short stage for us. So we need to be pushing and cracking straight on into REBA 3. And there is pressure on Welsh Government now to say, we need that funding, we need to move, we can't afford. The risk in us not moving forward is in losing design teams, losing expertise, and so it becomes a double whammy to the programme. So we need every day that we don't get decisions causes us a day on the programme. So we are working as hard as we can with our colleagues to mitigate against that risk. As I say, we're looking to demolish early next year, so visible sign of progress on the site, but also getting the site as ready as we can, starting to look at what other enabling packages can we do, how much can we pull out of the main construction programme whilst planning is being determined that will enable us to really crack on and get buildings open. I think it's just to say that there's a considerable amount of work going on over the next few months, as well as to reflect that has happened to date, but we will be keeping pressure on and trying to push hard and chipping away at that programme as we move through the next few stages.
Thank you. Yeah, I mean, it's really good, and Rosie and Glenn have done a lot of great work to get us to this place. I think the point that Glenn's making is, yes, it's about a building, but it's not about a building. It's actually about how do we actually change clinical practice and clinical pathways and different thought processes around what's the norms. And I think, Glenn's the example there about saying, our default will be, if having hip replacement, the default could be, it will be a day case unless there's a reason why it shouldn't be, rather than, oh, well, you might be lucky and you do it as a day case. We've got to move to that as default. We've got to say, outpatient surgery is the norm now, and people go in and get the procedure done and go home. So there's a big cultural shift, and Glenn and I were talking about this week, saying, as well as sort of physical stuff that's going to happen on that side, there's also that OD piece of work, the cultural change piece of work we're going to do with our clinicians, this is a very, very different way of working, and a very different way in which people have been used to working in our current services. But actually, the encouraging thing, I think, is the clinicians are really excited about it and see it as a really exciting opportunity, not just for what we do here in CTM, but in the wider region as well. And I think that's the big opportunity of this could be a real landmark facility, not just for us in CTM, but also across the region. And that in turn helps with things like recruitment of clinicians, recruitment of nurses, all sorts of different staff who will want to come and work in a facility like this. And it's absolutely key, going back to our clinical services strategy, it's key to enabling us to unlock other things across our sites that are key to our strategic plan. So really, really important piece of work, and it's great to see progress today.
Patsy.
Two questions. How intrinsically linked is the health park to the acute clinical services plan? So does one follow the other, or whatever?
Yeah.
And I didn't hear much about environmental sustainability in the development of building. I'm sure it's there. It just needs some assurance that every consideration is given to sustainability.
I'll pick up that last point, and then I'll do the shot.
Just to give the assurance, we will be following the net carbon zero target, and that's where we will be targeting the building. In terms of even the demolitions, there is an item by item list around how we can recycle, reuse, where we can reuse, whether it's on our scheme, whether it's on other schemes, whether it's a sell. So the actual waste associated with the demolitions is kept to a total minimum. And so all the way through the development, we are looking at procurement sustainability, trying to use local suppliers, trying to ensure that our carbon footprint is minimised as much as we can, but also in the efficiencies and how the building works moving forward. So we'll be maximising our use of PV, solar panels, looking at all the other opportunities that we've got, but principally it will play a role in every step of the development from the design to its up to the operational status, and that will be a forerunner in how the final design works.
Yeah, and just on your point, Patsy, about the service strategy, it's absolutely intrinsic to the clinical services plan, because it's an enabler that unlocks some other things that we want to try and do, and it also enables us to consolidate and bring together some of our surgical services, which are currently spread out across lots of different places, and it gives critical mass then of that. So part of what we will need to be doing as part of the clinical service strategy, describing how LHP is an intrinsic part of that, and the implications that could be on other sites as well.
Kath?
Yeah, I just wanted to say thank you and how exciting the whole project is, if you can call it a project. I was going to ask exactly the same questions as Patsy, so I don't need to ask any questions, but just to say massive thank you, and it's so exciting and what a massive opportunity, and obviously note the risks around getting the approvals through and how important it is to try and meet our timescales, isn't it? So I've noted that as well, so thank you. Yeah.
Rosie, really quick question for me. This is the first regional diagnostic and treatment centre that Wales will have. And going back to what I said, you weren't in the room earlier, but I was saying earlier that there's a challenge in Wales of understanding the demand for services and making sure we have the right capacity to meet that demand. In England, they have what, 160?
Yeah, 130
diagnostic centres. And I'm just wondering, in terms of looking elsewhere, are there things that we've learned from that to give us another view as to maybe what some of the other opportunities might be in how this site develops? So obviously, I think that flexibility is important. We started with a view as to what we thought this was about, but clearly the opportunity to think quite creatively, I think, is quite exciting. So what has that taught you?
So we've been in touch, in fact, I've got another one coming up with Norfolk and Norwich, where they built a 13-suite endoscopy CDC in England. So we're speaking with them at some point in October. We've also had a conversation with another CDC in England to learn where they've done diagnostics. We visited treatment centres in England, and my background is I was involved in the treatment centre programme in England. I was the clinical lead setting up Emerson's Green and Devizes and Cirencester back along. So I come from that as well as an NHS background. So I've taken clinicians across to Emerson's Green to look at that flow, that pathway. We visited Poole, where we went to look at barn theatres. We're going up to Swellock, which is a GERT recommended orthopaedic. They are slightly different because they have sort of anaesthetists on site and can do more complex patients in terms of comorbidities, but very much they're very efficient around their orthopaedic pathway. So we're up there later on this year to see their pathway. We've got a call in with Mason and Tunbridge Wells next week. We've just opened a new orthopaedic centre, elective centre, 3 theatres, 10 day case beds and 14 inpatient beds. Where they've got some lessons that they've learned from the build, so that call's in place next week or the week after. So we've done quite a lot of sort of looking around. We've obviously spoken with GERF to find out where are sort of the best places to go. So there's a lot that we've learned, the good things and what to avoid in some ways.
That's the thing, it's also one of the things to avoid doing, and I think that people have been through this process and then thought, oh, if only we'd known, we wouldn't have done it like that now. So we've got but I think, John, your point there about flexibility is really important, because we don't know what's going to happen in 5 years' time, 10 years' time. There will be new procedures. Endoscopy is a good example, right? So there's capsular endoscopy now, there's transnasal endoscopy. You don't need the big stacks necessarily. So we're trying to build the endoscopy suites to be as flexible as possible. And as Rosie said, some of the space may be repurposed into a clinic capacity or a treatment room capacity down the line. So the key, I think, is the flexibility question. But that also requires us to have standardised, and as Glenson and Rosie said, standardised kit. And I've been around many times, and people like Greg and I sort of seen these conversations over the years, you get a group of clinicians and everyone wants their own specified, I like it like this, I like to have the table on the right, I like to have the table on the left, and we build that in. Of course, what that does is it builds in redundancy down the line, because you've got a space that's not really going to be changed. So the other thing to remind ourselves is, if you go to the US, there are treatment centres doing orthopedic procedures in the back of like shopping malls, and backs of, so this is becoming a much more sort of utility sort of based model, which some of the high-end spec which we're used to in hospitals, we've got to get ourselves out of that mindset, because these sorts of facilities are becoming much more sort of standardised and high street based, which doesn't require such high spec as we've been used to in the past.
It's really exciting. I think we really appreciate how much has been done in what is quite a short time frame. So bearing in mind the last time we had an update to the board on where we had got to, clearly things have just moved on so quickly. And anything that we can do as a board, I know Paul's having these conversations, I'm having these conversations back with colleagues in Welsh Government, but clearly I know we are dependent on others being able to do the things that they need to do at pace. And obviously I know we'll need to have those conversations to try and put some more sort of bit of energy back in that direction as well. So I just really appreciate you coming here today, and it's fantastic to get this update.
Thanks, Rosie.
Keep us posted, and I'm sure we'll be seeing you again fairly soon. Thank you very much. Thank you. Okay, moving on to item 9, the consent agenda. Those items for approval listed 9.1.1 through to 9.1.5. Colleagues happy to approve? Those items were noting items 9.2.1 all the way down to 9.2.9. So we'll note those. There are no other items of business that I've been notified of. And in terms of this meeting today and how we've conducted ourselves and how the meeting is run, any observations, please come back to us within the next 2 weeks. There were no items today requiring an in-committee discussion on this occasion. Just to remind colleagues that in terms of the next meeting of the board, our next board meeting is the 28th of November. As you know, we've got our annual general meeting today at 2 o'clock. Members of the public are welcome to attend, but that is a board meeting, so I'm sure colleagues will be staying for the annual general meeting at 2 today. Rydw i'n dod y cyfarfod o'r Bwrdd Iechyd a Ben, a hofyn y diolch y bardd sydd wedi